It is my privilege to welcome Dr. Louise Hull, a professor at the University of Adelaide, Australia, gynecologist, reproductive endocrinologist, and fertility specialist at the Women's and Children Hospital, Adelaide. She will be speaking on individualized ovarian stimulation strategies towards truly tailored ART. Over to you, Doctor.
Thank you very much for inviting me today. And I've been asked to speak on individual ovarian stimulation strategies towards truly tailored ART. And now I've taken a pretty pragmatic approach looking at how you would make the decisions to do that. But I also would love to hear a little bit about what drugs you have available here and how you might be doing this differently to Australia, as we do have some limited ability to get some of the medications. I do have some funding and conflicts of interest, I was sponsored on an educational program by Organon. But when you talk about individualised ovarian stimulation, really all we are doing is moving that way. This is where we tailor our IVF medication protocols to each woman's unique characteristics to maximise pregnancy success and minimise complications. So our desired outcome is to get enough eggs to create a pregnancy without hyperstimulation syndrome and with minimal side effects and inconvenience. And basically we want to have a safe pregnancy and a live birth. And so we want to look at people as individuals. So if you are going to use an individualised approach, there are 4 things you are going to have to make decisions on. The first one is follicle stimulation and which FSH and which dose. The second is how are you going to suppress the LH surge. The third is which trigger, how are you going to prepare for implantation. And finally, we want to support the embryo in the luteal phase and beyond into the early pregnancy. So I'm going to go through each of those sort of paradigms of decision making that we use, but there may be other ways of doing this. So if we start with follicle stimulation, the recombinants have ended up being really our first line drug. So in the late 90s, we were able to actually develop cell lines like CHO yeast cells that were able to produce recombinant FSH, and polytrophin alpha and beta were produced, and we've been using them for a very long time. We use them on an international unit basis, and we titrate the dose. And most of us get very good at titrating the doses, working out what kind of level we want to use, and we adjust the doses. And they're easily given. They use pens and vials. The delta form of polytrophin is actually made in human cells, but it's a microgram dose. So you do need an algorithm, and it's based on AMH and weight, but it has been set at the lower end of the range of eggs we want. So it tends to be a slightly lower stim than the other two, and it comes as a single pen, so people use single pens each time. What we know is whichever of these you choose, they are really effective. They're all made in the lab, and polytrophin beta has a slightly smaller dose interval than the others, and it's got a direct effect on this receptor, so the others break down to affect that receptor. And particularly with the polytrophin delta, the dosage is a little bit different, so you do have to use the one you choose, but you do need to know how to dose and how to work out which dose. So if you look at the parameters, and I'm sure you're all doing this, the 2 main factors we look at are the ovarian reserve. If someone has low numbers of eggs, we're going to use a much higher dose to get them all, get the entire cohort. If someone has PCOS and a high ovarian reserve, we're going to have to limit the number of eggs we get at IVF so that they don't get hyperstimulation syndrome. And there are lots we can do to prevent hyperstimulation, and I'm sure you're doing these. The 2 main measures are AMH, or anti-Mullerian hormone, which is produced by the granulosa cells to prevent all your eggs going into the cohort too quickly. And the more AMH you've got, the more granulosa cells, the more eggs. And we get a very good estimate of the number in the cohort from the AMH. We can also count. We're getting really good at scanning now, and we can actually count the numbers. And again, that's pretty accurate. Now, this is a study carried out by Breuer and Ben Mole, and they wanted to compare the two to see which was the better one to choose, and they really found that they're both the best parameters to choose, and they're very equivalent. So either you use one or the other, or we tend to measure both anyway. What we know is that the other parameters are not quite as good. Age is not gives you a moderately useful prediction, but we've all had patients who are older who suddenly got lots more eggs than we expected, or younger patients who didn't have nearly the numbers and were on too low a dose before we had AMH and AFC. PCOS as a diagnosis is predictive, again moderately. Some people with PCOS don't have as many eggs as others. And BMI is actually not predictive of the number of follicles. The reason you would want to know about BMI is that it's to do with the PK mass space that you need to have the drug effect on the receptors. And you do need to increase the drug to be able to affect the receptors. So the other thing we have to decide is, when do you give LH and when do you give HMG? When do you need an LH supplement in a cycle? And we've got 3 different kinds. We've got human menopausal gonadotrophins, which are a urinary preparation, and the FSH and LH is in a 1-to-1 ratio. We also have now a recombinant FSH and combined with LH, and that's in a 2-to-1 FSH to LH ratio. And we can also use FSH and add small doses of HCG. And I'm sure you're all using those different medications. The whole point of this is, if you do not have enough LH, the thecal cells are not stimulated to convert the prostaglandins, the steroids, to androgens, which are the building block for estrogen. And the estrogen levels will be low in the follicles and around the egg, and that affects their quality and how they grow. So sometimes we do cycles and we see large follicles, but the estrogen's low and the endometrium's thin, and that's when we might want to add it. The situations where we'd add it straight up are hypogonadotrophism. I'm sure you all do that. That's going to be your high-level athletes, your Olympic athletes, or people doing lots of exercise, or people with eating disorders, people who are dieting very strictly. But there are some rare organic causes that you do need to be aware of, and sometimes there's an anatomical issue with the pituitary, or a genetic issue like Kalman syndrome, which means that they don't smell, and you have to just check that there's not a visual field problem or something else going on. Hemochromatosis can infiltrate the pituitary, so you have to be aware of that. And the other thing is Sheehan syndrome. If someone's had a very large postpartum bleed, they may have had not enough blood flow to the pituitary and the cells may have been injured. Probably the most common thing that I think we miss is people with PCOS who diet and exercise very heavily will have an issue with ovulation and an issue with stimulation because their insulin's high, and that affects AMH in the ovary and our ability to stimulate the ovary and the follicles. But they've dieted and exercised lots, and their BMI may not be high, and they also have low FSH and LH in the pituitary. And for those girls, you tend to think about using things like metformin, but also you would have to add an LH. Increasing age is another reason, and that's much more about, as you get older, the receptors in the ovary don't work as well, and you just need more FSH and LH to get them to do their thing, okay? And that's due to cellular reduced aromatase activity, mitochondrial dysfunction, and there are some transcriptomic alterations as well. So it's just about the quality of the eggs. They don't respond as well, and you need more drugs. Now, if you've missed something, if you've missed that mixed picture, and you do a stim and you see the big follicles and low estrogen, you can recover that quite well. And even up to a couple of days before the pickup, if you add LH or HCG at that point, the estrogen levels will rise very rapidly. So it is something you can change within a cycle. So we've kind of got an idea about doses, and we tend to start on about 150 for someone with a normal BMI and normal ovulatory response. But a lot of us actually see other people. We see people with PCOS where we have to reduce the dose a little bit. And we also see people with low ovarian reserve, and we don't actually see many normal responders. But sometimes we need to do things differently for our patients because of their needs. And there are some people we need to get more eggs than we would normally plan to do. And I think probably the best example is oncology, where you have one cycle, you have 2 weeks sometimes before someone's going to start chemotherapy, and the worst thing you could do is have someone with an ovarian reserve of about 18 eggs in the ovary, and you get the dose wrong and they get 4, and that's it for them. So we would be increasing our doses to try and make sure we get the whole cohort and manage hyperstim. And I'll show you the protocols that we would use, and we're very good at managing hyperstim, so we can push the numbers a little bit. Sometimes we have couples where they might get 15 eggs, but they get 1 embryo, and you just need a lot of numbers to be able to give them the embryo. Sometimes it's a male factor issue, where they get very poor fertilisation or very poor embryo development, and you just need more eggs to be able to get the few that get through to that blastocyst stage. Egg freezing is another reason. So we have a lot of young people who now are in busy jobs and are not going to be able to conceive for a while, but they might have slightly low ovarian reserve or be worried about their age, and it's expensive for them to do egg freezing. They would much rather do 1 cycle and get a good number of eggs, and we ideally would like 15 to 18 in 1 cycle rather than 2, where they have to pay a lot to get another cycle. So we don't want to do a bad stim for them, particularly when we're not putting embryos back. And the last is testing for genetic conditions. And that's where once we look at a couple who've got a recessive condition and 40 to 50% of their embryos will already have the wrong chromosome just from aneuploidy, we're then down to small numbers, and 1 in 4 of those we will not be able to transfer as well. So you need to start off with quite a high number to get back to where you are. Now, the one common characteristic of all those groups is they are not putting the embryo back in the cycle they're undertaking, and that's where we've looked at our protocols. Just so that you need to be aware that there are some people who actually you can't have a high dose. Some people just get too bad a side effects from the drugs, and they don't like estrogen and progesterone in terms of side effects, and we have to moderately stim them, or they just feel terrible. I've had someone with a mitochondrial enzyme energy disorder, and if you put stress on her cells, she would break down her muscles and get rhabdomyolysis, and we could not stim her too hard or she would get quite sick. We have people who've either had hyperstim before or they've had friends that have had it and just do not want to have really high egg numbers. And we do look after cardiac patients and renal patients, and they may not actually transfer the embryo, they might use surrogacy, but we can't stim them too hard. So we adjust the doses for the circumstances our patients are in. And the reason we can adjust our doses, particularly the reason we can push the egg numbers for some people, is because we have got antagonist cycles and cycles where we can actually do a cycle and not put an embryo back, and we can freeze embryos very well. So the methods we use to suppress the LH surge have really revolutionised what we do, and we've always used the long down regulation cycle, where we pull the plug out of the LH pool that's in the pituitary, and it just trickles away, so the estrogen levels are a wee bit higher, but you can't mount an LH surge. You need to use an ovidrel trigger. With the GnRH antagonists, which are really the most common and most popular cycles, what we do is we use we block the signal, but the LH pool is still there. So we can actually use it to trigger. And then progesterone is a new way of doing that, and we can take oral tablets to suppress the LH surge so that you don't ovulate early. So if you look at the long down regs, and I'm not going to tell you how to do a long reg cycle, I'm sure all of you are doing them, but we do start the cycle very early, and the first 7 to 10 days, most people suffer from hypoestrogenism. And so the side effects are higher, but the benefits, I think, help people with endometriosis by reducing inflammation in the pelvis, and that probably applies to adeno. It does bring the cohort of follicles together. And we would definitely use it if some of the other methods had a breakthrough and they developed a follicle. They ovulated early. And we do have very long cycles where we look at using lots of different medications over about a month when people have had really, really poor outcomes to try and precondition the cycle. And we're often using a GnRH agonist to help us do that. We can't use it if you cannot use an antagonist. You cannot use an agonist trigger in a long down reg cycle. So you are forced to use Ovidrel, and there's going to be a risk of hyperstim. If you get a lot of side effects, we wouldn't use it. And it's too long to use if we want urgent treatment. And finally, people who are very sensitive to hormones, that would not be your first pick. And generally, this is a second-line treatment now, but it was all we had in the 90s. What we've done is we've managed to get antagonist cycles, and this has enabled us to do shorter cycles. The side effects are much easier for people to manage, and also we can use a short-acting LH trigger by using an agonist to release the LH from the pituitary. And basically, now that we've got really good at freezing embryos, we can actually use that very easily. And a lot of the time, we're using frozen eggs and embryos rather than fresh embryos. And all those scenarios that I gave you were where we actually would do a freeze-all, because the main risk of hyperstim is if people get pregnant. Now, is one better than the other? And there's really good evidence now. They've got a Cochrane review to show that in terms of this assisted reproductive pregnancy outcomes, those cycles are completely equivalent. So we can use one or other very safely. We would expect the same outcomes. You just have to know how to do them and be good at them. And generally, we do a lot. The one thing that is different, however, is that the antagonist cycles give you that opportunity to manage hyperstim much better, and we are not seeing the levels of hyperstim that we did when all we had was a long down regulation cycle. In terms of minimising the risk of hyperstim, the main issue is when you use the trigger, small blood vessels grow into the ovary, they don't have, they're immature, they don't have pericytic coverage, and they leak. And when you have one follicle, that amount of fluid doesn't count very much. But when you have lots and lots of follicles, you get ascites and you get fluid shifts and electrolyte shifts in the blood. And you've all seen it and you all know about it. This is a protocol we use. We always use an antagonist cycle. We use metformin. It reduces the risks of hyperstim, so we use a lot of metformin. We freeze the embryos. We use an agonist trigger, and we start carbergoline after the retrieval, and we do not transfer an embryo. And I'm sure you're all doing that. We've moved on to progesterone prime cycles, and this is where you use an oral progesterone on the same day you start your FSH, and it suppresses the LH surge. But the advantage of this is that you do not stimulate the endometrium. So the people who it's really good for are people with endometriosis, where you do not want that stimulated, and who don't like having a painful, heavy period after, which you can get in the other cycles. So we're using it a lot with egg freezing, and as we're doing a lot of non-invasive diagnosis of endo now, a lot of younger people are coming to freeze their eggs because they find out from a scan that they've got endo and that their egg numbers are a little bit on the low side. So there's more happening. What you cannot do, though, is if you have a couple wanting to conceive and wanting a fresh cycle, and we were planning to freeze all or do PGTA, if you have poor embryos that you can't test and you can't freeze, you cannot transfer that embryo because the progesterone has made that endometrium completely unreceptive. So in cycles where people are actually hoping to have a baby and you're not sure what your embryology is going to be like, it's much safer to use orgalutran. In terms of efficacy, and there have been meta-analyses. There have been about 9 randomised controlled trials, but the problem has been they've compared them to different stims. 5 have been antagonist cycles, 1's a natural cycle, 2 are short agonists, and 1 was a long downreg. And those comparisons are all a little bit different. However, they really didn't see any difference in clinical pregnancy and live birth rates. So we believe that it's pretty similar, and certainly we use it and we find the outcomes are about the same. Both the antagonist cycles and the PPOS cycles give you another advantage because you can do random stimulations and start at any time in the cycle, which you can't do with a long down reg. And this is really helpful in oncology where you have a very short time frame and you can and it grabs the wave of eggs that is continuously trying to grow in the ovary. And you can grab that at any time and stimulate, and you'll get this cohort. Now, if you do that when there's a follicle or a corpus luteum, there'll be one lead follicle or corpus luteum, but there'll be the cohort that grows underneath. So that's really changed what we've done in terms of people who are urgently needing treatment or people who are leaving the country or have got commitments they can't change and they need to do egg freezing, or they have a surgical date and they've suddenly decided to do egg freezing. You can do random starts. They start at any time in the cycle. You use antagonist cycles and you don't wait for a period. And the thing that it does is it reduces the time to the pickup. And for people in oncology, that's really important. Duostim is where you do a second stimulation a very short time after you've done the first. And again, the main area that this is used in, and it's usually 5 days, is in oncology, where you've got enough time to do 2 stimulations, and you might have someone with a lower ovarian reserve, and you can do a duostim. As you stop, you wait 5 days, you don't care whether they get a period or not, and you start again. The main issue with this is it's quite hard for the patient to be doing cycle after cycle, but in an oncology setting they want to. And there are also people who have low numbers that might want to do PGTA, and they take the eggs, grow the embryos, test them. In the meantime, they're doing another cycle. So it can work very well, and it's fine to do. The other thing is triggers, and I'm going to talk a little bit about the problems you can have with triggers, and there are 2 main problems. One is that you can get ovulation before you get to the pickup, and it's very frustrating. It's a very small number of cycles. I'm sure we've all been there. And it is sometimes due to a premature LH surge that's broken through your suppression, but I think there's also natural variation. Some women have a longer time between the LH surge and releasing an ovulation. And if you're in the moment, you can actually sometimes retrieve eggs from peritoneal fluid around the ovary if you're in doing a pickup. You've got to ensure that they've actually taken the medication and they've taken it at the right time. It might be they took it at 2 hours early and they've ovulated before you've got to theatre. Sometimes they haven't taken it correctly, and if they've had an ovidral trigger, you can actually check that by testing follicular fluid. And if that's happened and you're seeing them again, sometimes if you don't let the follicles go quite so long, you're less likely to get an LH breakthrough. You can reduce the time interval, and also you would go, when you go back for the next pickup, you'd always do a scan before you start and just make sure the eggs are still there before you give any kind of anaesthetic. The other thing is when you just can't retrieve the eggs, and that happens reasonably frequently, and some people it's very specific. And that happens a little bit more commonly than ovulation, early ovulation. Again, it can be the trigger administration, but it's probably most commonly atretic follicles, and it's most commonly in older people where the eggs are just not responding to our drugs very well. Again, we'd check the HCG in follicular fluid, and we'd give it, you can actually, if you've taken the eggs, if you've tried to get the eggs out of one ovary, found there's no HCG there, you can trigger for 2 days' time. You can come back and do another pickup in a couple of days' time with follicles from the other ovary. So it is possible to recover it. But again, often it's been a medication issue. If you're planning the next cycle, you would organise to trigger a little bit earlier in the cycle, so that there's a little bit more time, and you would increase your dose interval and also do a double trigger. Now, you can do a double trigger with Ovidrel, but not with an agonist. You can use one agonist and Ovidrel, but you can't double the agonist dose because the LH is capped in the pituitary. The last part that I'm going to talk about is about progesterone. And basically what we want to do is really avoid that little dip there dropping too low and getting progesterone withdrawal and prompting the endometrium to shed when you are trying to get implantation. And that's where we use a lot of progestins. They support the corpus luteum, they stabilise the decidua, and they reduce myometrial contractility. The side effects can be quite significant. They're all the side effects women get just before a period, all the PMS type of symptoms: breast discomfort, constipation, fatigue, low mood, nausea, headaches. There's been a lot of work looking at which progesterone, and there's a lot of companies that will tell you one is better than the other. The main issue is that you've got choices, and I think this is where individualising with your patients is the best policy. So vaginal preparations have been around a long time. I think that's probably my first line, is to use a vaginal preparation because I can access them easily and I have a lot of experience with them. But there are now subcut and IM preparations, and there's also oral preparations. And in Australia, we actually find it quite difficult to access oral preparations, but the others are fine. So we do measure blood tests, and if we found there was a drop in estrogen, we would be much more inclined to use an HCG trigger as well, and try and trigger the corpus luteum to make both estrogen and progesterone. But if the progesterone had a significant drop, we would increase the dose, or more commonly, we would use a second type of progesterone. What we do know is when we use vaginal preparations, there's a first pass effect through the uterus. So the levels in your blood are actually much lower than the levels in the endometrium, and it goes through the uterus and then ends up in the blood. So you do actually get higher doses than what you will measure when you use vaginal preparations. The last thing is, do we keep the progesterone going, or do we stop it? And the reason you might keep it going is to try and reduce the risk of early pregnancy problems. And the first question is, do progesterones reduce the risk of miscarriage? And that was a very controversial problem until we had two huge trials out of Tommy's in London. The first one was PROMISE, and it had just over 2,000 patients, and they did not see an effect of the use of the progesterone. But then they used PRISM, and they ended up with 5,000 patients. So it took a very large number of patients to see an effect. But when people had three or more miscarriages and had bleeding in pregnancy, there was a significant benefit to using progesterone. From a biology point of view, and that's where I work in reproductive immunology in Adelaide, the immune cells move from the M1 inflammatory prototype and behaviour to M2 healing and repair, and that helps remodel the placenta. So it makes biological sense as well. So in summary, individualised ovarian stimulation gives our patients the best chance of having a successful IVF cycle early in their fertility journey, while we minimise the risks and maximise the chance of a healthy term pregnancy. So I'd love to hear some of the thoughts you have, and hope you this helped today. I've got a lot of people I work with, and I'd like to thank all their help.
Thank you so much, Doctor, for that thought-provoking session. May I now please request Dr. K. Jayakrishnan to kindly present a token of appreciation to Dr. Louise Hull. Dr. Louis. Thank you, Dr. K. Jayakrishnan. Thank you, Pratap sir.